Hey everyone, welcome to the Facebook Live this afternoon. My name is Paul Switaj. I work for OrthoVirginia, and we're going to be talking about a pretty exciting area in the foot and ankle community at this point in time, called more minimally invasive surgery, which is a core part of this burgeoning technology. And so thought I'd talk to you all about that a little bit, and specifically in addressing kind of bunions and kind of lesser toe deformities overall. So we'll start with just who am I, right? So I was actually born in Minnesota, but I grew up in Farmington Hills, Michigan. So I usually point to that little area on your palm there. I went to undergrad at Notre Dame. I did my medical school at Georgetown. That's why I'm back in this area. Did my residency, which is 5 years for orthopedic surgery at Northwestern in Chicago. And I got sick in the Midwest. Did a year of foot and ankle fellowship, so 1 year after my orthopedic surgery training in Baltimore. And then I've been at OrthoVirginia now since 2016. So I just specialize in foot and ankle reconstruction within orthopedics. I've been married since 2013. I have 3 wonderful daughters there. You see pictured there, a boy dog named Bruce. I live in the Broadlands, like in Ashburn, and happy to be practicing at the OrthoVirginia. So we're going to talk today about bunions, or hallux valgus deformity, okay? So bunions are much more than just a bump on the foot, okay? It reflects a change in your bony structure and alignment, okay? So it's a very important part of the treatment, okay? The toes get misaligned, and then the soft tissues stretch out on one area, tighten on the other area, and that leads to kind of that gradual worsening of that deformity. Why do people have bunions? Like anything in life, it's a multifactorial. There's definitely a hereditary component. So I hear all the time people coming in being like, hey, my mom, my aunt, my dad has these bad bunions, and I'm starting to get them as well. But there's also a significant shoe wear component as part of that as well. Wearing tight, narrow shoes can certainly exacerbate any predisposition or deformity that you have. And like I said, it's usually a combination of both those factors, right? That contributes to that deformity and that pain associated with it. So symptoms of a bunion. So that what we call that, we have that pain, that soreness. On that cartoon, you see mainly on the big toe. You can get them in the little toe too. That's called a bunionette or a tailor's bunion. So you can get them on either side, but that's gonna rub, especially in shoe wear. So that causes inflammation, swelling, and redness, like you can see from this kind of clinical picture here too. Sometimes it gets so bad people get calluses due to the pressure changes, again, predominantly in shoe wear, but as things progress along, people can have pain regardless of what kind of shoes they wear, where they make a lot of modifications, but it's still particularly painful overall. Like anything in orthopedics, treatment usually begins with conservative treatment, okay? An important part for the bunions, okay, is that there's nothing that's really been proven to slow down the progression of a bunion or to correct a bunion non-surgically. So this is a screenshot I pulled off of Amazon showing these splints, these braces, someone for $200. There's absolutely no evidence to support that that actually corrects the deformity. Now, it can help your symptoms, so it's not saying that these are bad things for you overall, but just don't expect it to make your toe more straight. Other than these fancier devices, most of my patients wear some padding or spacers. Again, treating the symptoms and the shoe wear irritation can be all that a lot of people need when it comes to these pathologies. I mentioned this a few times, but shoe wear is really important, right? So you look at the toe box where the bunion is and just making sure there's no prominence or pressure on that area of your toe is important. So I hear all the time people have dozens of pairs of shoes in their closet they can't wear. And that's unfortunate, but sometimes it's necessary as we age and as the pain evolves to change our shoe wear as well. So not everyone does well with that treatment though. Some people still have persistent pain, right? So there's we can do what generally referred to as a bunionectomy, right? Now, any surgical correction for the bunions require cutting and shifting of the bones, unfortunately. Okay, and that's because it's the deformity, right? It's not just a bump. If it was just a bump, I could shave that off and that would be a quick and easy solution. But because of that deformity, we have to correct that deformity to give us longer lasting symptom relief overall. Once we cut and shift that bone over, we then have to put different types of metal in there to hold it in place. Once we do these what's called osteotomies, the metal holds it so we can permit early weight bearing and help with the healing of the bunion. Now, there's been so many different ways described on how to do this, right? So these are just pictures I took from the internet about different types of procedures to correct that alignment, right? So a little bit of which procedure you need is based on how I'm trained or someone else you're seeing is trained, based on your degree of deformity as well. So those are things that play a role in clinical decision-making processes with what specific procedure that I would recommend for you. So for bunion surgery in general, pros is you get a straighter foot, right? We can correct that alignment, make shoe wear a lot more comfortable, right? Alleviates that pain and rubbing, right? That's a great thing for a lot of people, right? The cons, right? You have to cut and realign the bone like I talked about. That's not a pleasant experience overall. The bunion sometimes comes back with surgery, right? Now with proper techniques and assessment, we can minimize that risk, but that's always a potential possibility. The hardware, the screws that we put in sometimes can irritate people, necessitating another surgery. Traditionally, we've made larger incisions to help correct these bunion. So that's what I'm going to talk about a little bit upcoming here is the minimally invasive approaches can decrease those scars and that incision, allow for a little bit better healing, a little bit better cosmesis associated with it as well. And the thing I tell my patients about is long recovery, right? That's why that explain exactly what causes it, the deformity, the correction, right? Realigning the foot takes some time not only to heal from a bone perspective, but just to get used to. Your foot's going to be in a different alignment that it's been for sometimes decades, right? Expecting that to feel better right off the bat, not possible, right? But we get you going quicker and quicker. And that's why, again, the minimally invasive approach is helpful in that regard. So again, the pros, when we're talking about the more minimally invasive surgery, where I utilize several small incisions, still to proceed with the same cutting and shifting and position of the bones, but through a much more minimally invasive approach. That means the pain is typically less, so people need less opioid pain medication after surgery. It creates a lot of better cosmesis. You can see here an example of the more minimally invasive approach on the right, the more traditional open approach on the left, okay? Now these skin incisions heal, people do well with either one, but obviously the cosmesis and the scarring is much better with the more minimally invasive approach. You typically get less stiffness. So with realigning the bones, again, your toe's not exactly used to this, but with all the big incisions, that open approach, this toe would be straight, but it would be stiff, right? And so you have to make that trade-off. With the more minimally invasive approach, we can preserve a lot of that motion, decrease stiffness, while also maximizing your longer-term outcomes. Cons for the minimally invasive is that's not for everyone, okay? Sometimes if it's the bone quality is very poor or the deformity is very severe, it's not a good approach, okay? In addition, we get x-rays in clinic to see if you have any degree of arthritis associated with the bunion, which can change treatment kind of a process as well. We're going to go a little bit through surgical technique and then a couple little instances of cases, just how I do this, okay? Using cartoons, don't worry. So this is a side view of the foot, right? So we draw out the metatarsal here, and usually I do this in surgery too, just to get my landmarks, okay? And then you can see this little small incision we made, just with a little scalpel blade here around that area. This is called a distal metatarsal osteotomy. This is where we're using this predominantly for the bunions. You use these little elevators to help move the skin and soft tissue out of the way. And then if you see that dotted line in there, that's kind of the proposed cut we're going to make in that metatarsal, and then shifting it over, which you'll see in the next slides. The minimally invasive evolution over the last like 5 to 10 years has really been because of these new burrs that have been developed, okay? The way the burrs are processed have very little harm to the soft tissue, but they're really good at cutting bone. Because minimally invasive approaches have been around for decades, but they did not have the best equipment. So the early results from minimally invasive surgery were poor, okay? But now with better fixation techniques and these better burrs, it's been safer for patients and more reliable to get people going a little bit quicker. So we basically make these bony cuts. And then in these next slides, you'll see these devices. And there's a lot of them out there available. It doesn't really matter which one it is, but these devices to shift that metatarsal head over and putting screws in place, all right, so that your body will heal in this better alignment, okay? I usually try to show everyone a picture of one of my patients with these or look online because it looks strange at first, right? But what you want to see is the overall alignment of the foot, and that bone cut will heal. It'll take months and months of looking at it on x-ray, but you'll feel better clinically before everything looks perfectly healed on your x-ray. So this is just an example of an x-ray. Here you can see the prominence on the inner aspect of the foot. We draw these lines, this just assess the degree of deformity, okay? And then you'll see this that on the x-ray, as they come in here, these are what's called the sesamoid position being off. Another line here demonstrating like the bump where you see this blue line come in here. Right, and then you'll see kind of the after coming up through here, right? Well, the lines are much straighter. That metal stays in there forever, okay? If it does bother people, you can take it out after the bone is healed. But you can see how the prominence on that inner aspect and those little bones called your sesamoid bones are much better lined up now because of that shift in the metatarsal head. Right, so that's kind of a before and after example of an x-ray, okay? Recovery is very, very important for these, right? So being educated about how long it takes, the postoperative care is really important, right? So typically for the first 2 weeks after surgery, you can wafer on your heel in a special shoe, okay? It's not the most comfortable shoe in the world, but it permits you to be up and about, right? Usually mainly around the house, right? Then weeks 2 to 6, we transition to a flat, stiff shoe, okay? And then into sneakers. I tell people my whole goal is to get you back into like a comfortable shoe, mainly a sneaker, in about 6 to 8 weeks from surgery. So at that point, you can start slowly increasing your activities, your exercise, so that you can get kind of that full return at that 10-week plus, all right? Now, it doesn't seem like that's very quick, but quicker than it's traditionally been for sure. But you have to put in your mind that it's going to take this amount of time. Again, like we talked about, the bone has to heal, your swelling has to decrease, and your foot's got to get used to it overall as well. So this is just a clinical picture here, right, of a patient going from this to that overall. Okay, now you can still see it's some swelling, but remarkable improvement in the alignment of the big toe overall. So that's kind of the meat of the minimally invasive approach from the bunion. Now, we have started to adopt this more minimally invasive approach for other areas around the foot and ankle as well. I'd say it's predominantly used for bunion. We're starting to use it in other applications as well. One of them is for the hammer toes. So associated with bunions, sometimes people do get the hammer toes, right? So that's that abnormal bend in that second toe. You can see this clinical example here. The person has the bunion plus the hammer toe. So these two things do go hand in hand, okay? Sometimes the bunion causes the hammer toe, but this is what we're talking about symptoms. A lot of irritation with shoe wear, as you can imagine, that rubs on the top of the shoe, right? You can get calluses and corns associated with this that can be very, very annoying and frustrating, painful for people. Redness, inflammation, sometimes we can even get wounds or sores or infections because of that rubbing overall, okay? Why do people get hammer toes? Like I said, sometimes it's associated with bunions or other big toe problems. Poor shoe wear, overloading the lesser toes, and there's a component definitely of age and neuropathy that plays a role. So not every hammer toe is the same. Sometimes it's in conjunction with other issues. Again, in the big toe is a very common one overall. So for treatment, again, easy stuff first. There's a million different things you can strap around these, pad it up. Shoe wear changes, again, are very, very important, right? You kind of get the picture after talking about the bunions, right? There's really easy things you can do. But again, nothing's going to correct it. Nothing's going to realign it. We're just trying to help your symptoms, right? And in a lot of people, if they, hey, if my toe feels great wearing this wrap, I don't need surgery, then great. That's okay. I'm trying to make you feel better overall, whether that's with a little piece of plastic you can get online or with a surgery. And that I'm okay with either one of those. But not everyone does well, right, with those. Sometimes there is some continued irritation. They've tried to repair a shoe in the world and it still continued to bother them. So then what you do is you take out, like you see in these cartoons here, you take out basically part of that knuckle, and then the traditional treatment is a little metal wire to hold that straight so that your toe heals in alignment. Now that creates an incision on the top part, a little piece of metal that sticks out of your toe, believe it or not, for about 4 to 6 weeks. So that's fine. The advantage of that, you take it out afterwards, so you don't have any metal left in your foot, but it can be pretty aggravating for people in that recovery time frame.
Just want to mention that the next picture is slightly more graphic than some of the other pictures. So wanted to give people a warning.
It's smaller though. So then this is like a post-op recovery picture. So you may have seen some of these from your friends online that are posting this, but on the left side, this is just maybe a little bit more dramatic representation, but smaller incision approach versus the bigger incisions from a more traditional approach. Now, either one of these is fine, right? But you can tell that with the smaller incision approach, you're going to be healing up quicker. You're going to have less swelling and less pain. Same sort of pros and cons as it comes with the bunions or with the hammer toes as well. Okay. And I'll show you a couple kind of x-rays examples here. Okay. So this is someone you can see, if you click one more, you can see how crooked these toes are, right? And so this is causing, this could be causing a patient a lot of irritation with shoes. Okay. And with smaller incisions, you can see afterwards, this is kind of a before and after representation where everything's pretty straight. So she's happy, better, she can be better in their shoe wear with less wound problems overall. Okay. And just one more example here where you can see this little rectangle out of the toes kind of bent like this, and then the after where everything's nice and straight in through here. Okay. That screw is buried into the bone, so there's no pins or wires in place. So that makes life a little easier afterwards. And then a side view of that picture where you can see how crooked that is beforehand, and then you can see kind of how straight it is afterwards. Okay. Usually for the hammer toes, you get to walk on it right away. Now it's not, again, comfortable, but you walk in a flat, stiff shoe and you're basically curtailing your activity or minimizing your activity for a good 4 to 6 weeks afterwards. But a lot of times I feel I have to kind of pull my patients back a little bit because they want to do more earlier just because they're feeling better. But I think that's about, again, this minimally invasive kind of revolution in foot and ankle is interesting. I was definitely not a super early adopter, but I really got on board over the last 5 years, just as I've seen the results with my patients and with talking to my colleagues around the country, just how beneficial this is for patients to approach these, more significant deformities and to correct the toes and make my patients' lives better overall.
Thank you so much. We will take questions now. We will be answering questions that were submitted earlier and questions submitted live. So if you are watching this live on Facebook, please feel free to put a question in the chat. We will answer as many questions as we can, but not all questions will be able to be answered. So one of our common questions that we had beforehand is, when should someone consider bunion surgery?
Yeah, so it's basically when you've had enough of trying the easy things, right? the hard part that I talk to my patients about is like, look, for bunions, you do the really easy things, right? Change your shoes, wear the padding or the spacers, or you have surgery. There's not a lot of middle ground, right? This isn't something we can physical therapy out of yet, right? So when your frustration level grows and you're properly informed about what you're getting yourself into, right? So education is super important, especially for bunions, right? But it's still an elective procedure, right? You elect to do it, right? A typical speech is when it affects your quality of your lifestyle, right? You've tried to do the easy things, right? You know what the surgery entails and what the recovery is, and you have time, right? Because that's an important part about that as well, right? So if you've had all those things or thought about all those things, then it's time. I see plenty of people who are like, this is bothering me. It's not that bad. I'm like, just come back and see me if it's bothering me even more. So sometimes I'll see this patient a year later and then like, it's time. Other people, they're dead set on it when they come in. They've seen a couple people before. They've been trying to modify their shoe wear. Their whole closet is full of shoes they can't wear. And so it's different for every person, right? Overall. And it depends on your activity and age as well. How long you need to take to recover.
Thank you. Is there an age limit on the treatment options you've discussed?
That's a great question. So technically, no. Personally, I actually have a lower age limit that I won't like to do. So people that are teenagers, like, don't like to do surgery when they're too early or less skeletally immature. Hopefully they're not on the Facebook Live right now. But for the older patients, it kind of depends on bone quality, right? So the advantage of the more minimally invasive approach is you can get up and move around. The complications are less overall. So it really just, for me, depends on if you have like severe osteoporosis, sometimes that's a little harder to do overall, but no upper end of the age limit for me. It's just, that is more tied into like recovery, how you can get around afterwards, how feasible it is for you to be, take care of yourself afterwards.
Thank you. Can you do multiple foot or ankle surgeries at the same time, such as correcting a bunion and correcting hammer toe on the same foot?
Yeah, absolutely. So that's a very common thing to do. Like I mentioned with the hammer toe, sometimes the bunion's bully creates second toe problems. So I saw a patient this morning who, her bunion wasn't even bothering her, but it was wreaking havoc on her second toe. She had a lot of irritation over that area. And so sometimes you have to move the bunion out of the way to create the hammer toe, or to correct the hammer toe, sorry. And so it's done pretty commonly in conjunction with each other. You don't have to like stage that or do it as two separate surgeries. To dovetail this, people also sometimes mention like, hey, can you do both at the same time? Like if they have two bunions, really, really try to stay away from that, okay? Some procedures I do, like if you have two hammer toes on both sides, that's something where I let you weight bear on it right away, so I feel more comfortable with that. The earliest I've ever staged bunions is 6 weeks apart from each other. I'm a teacher who wanted to get done during the summer before school started, and even that's pushing a little bit because you want to make sure that your foot's recovered enough to do the other side. Plus, I want to make sure you're happy with the results.
Thank you. Is there any physical therapy required after the bunion surgery?
So I don't do it as a matter of a routine. I never discourage people from doing it. I think a lot of it has to do with your life and everything you have going on in it, plus how stiff you are afterwards. So we kind of gauge that at the first kind of 2, 3, 4 weeks after surgery. And it's really just addressing mobility, any gait related problems that you have. But certainly walking differently for a couple months after surgery sometimes problems people's knees or hips temporarily. So sometimes after the fact or a little later on, we'll do therapy, or to get back to like your strenuous exercise activity. Sometimes that's helpful due to the immobility beforehand or during the recovery.
Thank you. Can you have a bunion or hammer toe surgery if you have osteoporosis?
Yeah. So I think it's definitely still possible, right? There are ways that I change a little bit from a fixation or a weight-bearing standpoint afterwards in some patients, but it certainly does not preclude surgery. Hammer toe, really not at all. Bunions, again, I adjust my process a little bit with it overall. with the recovery and with the fixation I use intraoperatively.
Can irritation in the third and fourth toes be because of bunions or only in the second toe?
It's predominantly in the second toe, but you can certainly have irritation in all the lesser toes as well, a little bit based on the severity, but also based on the way that you start to walk, right? So when you have the bunion, oftentimes you walk a little bit more on the outside of the lateral border of the foot, just to either avoid pain or because the mechanics of the foot force the pressure onto those areas. And so that can cause some changes in the toe. So it can certainly be, those lesser toe deformities can be related to the bunion.
Thank you. Are you sedated during surgery?
Yeah, typically for most of these procedures, two major options. One, you could have what we call conscious sedation, where you're awake but sedated with like a regional nerve block. Most of my patients, so one thing I did mention was like how long surgery takes, right? So that is depending on how many other procedures we have to do. But standard, minimally invasive metatarsal osteotomy, the ones that I was, showing you guys, takes about an hour, okay? And so usually it's just a quick general anesthetic for most of my patients, but that's something we discuss in clinic and then with the anesthesiologist beforehand. So there's different options. I would say most of my patients will do a general anesthetic and I'll do local anesthetic around the surgical site to provide pain relief, but it's certainly a discussion between me, you, and the anesthesiologist.
Thank you. How soon can you drive after a bunionectomy on your right foot?
Great question. So first off, you have to be off all pain medication, right? For 2 weeks, no way, all right? So when you are starting to weight bear comfortably, usually that's around 3 to 4 weeks afterwards in the flat, stiff shoe, you can drive, right? Obviously, you want to make sure you're safe and to make sure that, you're not harming yourself or others. But I think on average, I would say a month is a very conservative estimate, but you can do it as early as 2 weeks, depending on how you're feeling and how much pain you're in.
Thank you so much, Dr. Switaj. That is all the questions we have for today. Would you like to close?
I just appreciate everyone's time and availability. And I think they were talking about, but I'm available like in our Reston office. I go to Ashburn and our Aldi offices as well. A couple other foot and ankle providers that are more like kind of on the eastern part of the our region here too. So we're all well trained and just looking to hopefully help you guys feel better.